Chapter 5: A Modern Approach for Treating Scoliosis. Highly invasive spinal fusion surgery for scoliosis has long been considered the definitive treatment for severe spinal curvatures, particularly those exceeding 45 to 50 degrees. This procedure, which typically involves the permanent fusion of multiple vertebrae using metal rods, screws, and bone grafts, aims to halt further curve progression and stabilize the spine. While fusion surgery can dramatically reduce the degree of curvature in the short term and is sometimes necessary to prevent life-threatening spinal deformities, it is not without serious risks, both immediate and long-term. In the short term, patients undergoing spinal fusion are exposed to the inherent dangers of major surgery, including complications from general anesthesia, significant blood loss, infection, nerve damage, blood clots, and adverse reactions to implants or bone graft materials. Surgical site infections in particular can be devastating, sometimes requiring removal of hardware or additional surgeries. Spinal cord injury, although rare, can occur during instrumentation, leading to partial or complete paralysis. Recovery from spinal fusion is long and arduous, often requiring several months of restricted activity and physical therapy to regain basic function. Beyond the initial recovery, the long-term implications of scoliosis fusion surgery can be profound and life-altering. Chronic pain is one of the most common long-term complications, affecting a significant proportion of patients. Despite achieving structural correction, many individuals report persistent back pain, stiffness, and reduced spinal mobility, which can severely limit their daily activities and quality of life. The fused sections of the spine no longer move naturally, placing increased biomechanical stress on adjacent unfused segments, a phenomenon known as adjacent segment disease. ASD. Over time, these compensating areas can develop degenerative disc disease, herniations, arthritis, or new curvatures, often necessitating further surgical interventions. Moreover, the irreversible loss of spinal flexibility can impair athletic performance, simple activities like bending or twisting, and even natural gait patterns, which may accelerate musculoskeletal wear elsewhere in the body, such as the hips, knees, and feet. One lesser-known but increasingly concerning issue with long-term spinal implants is the gradual corrosion and breakdown of the surgical hardware itself. The metal rods, screws, and connectors used in scoliosis fusion are typically made from titanium, stainless steel, or cobalt chromium alloys. Although these materials are selected for their strength and biocompatibility, they are not immune to the mechanical and chemical stresses inside the human body. Over years or decades, microscopic wear, fretting, and corrosion can release tiny metal particles and ions into surrounding tissues and the bloodstream. This phenomenon, called metallosis, can trigger local inflammatory responses, pseudotumor formation, tissue necrosis, and systemic symptoms such as chronic fatigue, cognitive impairment, or allergic-type reactions. Studies have documented elevated levels of metal ions such as titanium, cobalt, and chromium in the bloodstreams of long-term fusion patients, raising concerns about potential systemic toxicity and long-term organ effects, though this remains an evolving area of research. Furthermore, revision surgery to remove or replace corroded or failed hardware carries even higher risks than the initial procedure, with greater chances of infection, nerve injury, and poor outcomes due to scar tissue and compromised spinal structures. Psychologically, many patients experience significant emotional and mental health challenges following spinal fusion. Feelings of regret, depression, anxiety, and frustration are not uncommon, particularly among young patients who were unprepared for the lifelong physical restrictions and chronic discomfort that can follow surgery. The belief that surgery would fix their scoliosis is often replaced by the realization that their spine and their life has been permanently altered, sometimes without achieving the level of pain relief or function they had hoped for. Given these risks, it is increasingly important for patients and families to fully understand that spinal fusion does not cure scoliosis. It merely stabilizes the curvature in exchange for significant functional and biological costs. While in certain severe or rapidly progressing cases, fusion may still represent the best available option, it should never be presented as a benign, simple solution. Alternatives that focus on earlier, proactive, non-surgical interventions, including scoliosis-specific exercise programs, neuromuscular retraining, and addressing underlying biological drivers, deserve much greater emphasis within the scoliosis treatment landscape. By shifting the focus from crisis management to prevention and whole-body health, the need for highly invasive surgeries and their associated complications may be significantly reduced. In summary, scoliosis fusion surgery is a highly invasive, high-stakes procedure that carries serious short and long-term risks. Immediate surgical dangers include infection, nerve damage, and recovery challenges, while chronic pain, loss of spinal mobility, adjacent segment disease, and systemic issues related to hardware degradation threaten long-term health and quality of life. The growing awareness of metal ion release and its potential systemic impacts further complicates the risk-benefit analysis for fusion surgery. Patients and families must be thoroughly informed and actively involved in decision-making processes, weighing all available options before committing to a procedure that permanently and profoundly alters spinal function and personal health. Genetic variant testing for scoliosis. The importance of genetic variant testing for adolescent idiopathic scoliosis, AIS, cannot be overstated, especially as our understanding of the condition continues to shift from a purely structural spinal deformity to a complex systemic disorder influenced by multiple biological pathways. Traditional scoliosis management has often relied on observational methods and generalized treatments, but the advent of precision medicine has opened the door to a new era of individualized care. Genetic variant testing, when combined with specific hormone and neurotransmitter profiling, provides invaluable insights into not only the root biological causes behind an individual patient's scoliosis, but also informs personalized dietary, supplemental, and therapeutic interventions that can dramatically improve outcomes. At the genetic level, numerous variants have been associated with increased susceptibility to scoliosis development and progression. For instance, variations in genes responsible for connective tissue integrity, such as FBN1, fibrillin 1, and COL11A1, collagen type 11, can predispose individuals to weaker structural support within the spine, making it more vulnerable to abnormal curvature. Likewise, polymorphisms in bone metabolism-related genes like VDR, vitamin D receptor, and PTHLH, parathyroid hormone-like hormone, can affect bone strength, density, and the delicate balance of growth during puberty. Genetic variants impacting neurotransmitter function, such as COMT, catechol-O methyltransferase, and MAOA, monoamine oxidase A, influence proprioception, balance, and postural control, all critical systems implicated in scoliosis development. Understanding a patient's unique genetic landscape offers profound clues as to why scoliosis has developed in the first place, rather than treating the condition as a random, idiopathic occurrence. However, genetic predisposition alone does not guarantee curve progression or severity. Environmental triggers, epigenetic factors, and the body's internal biochemical environment heavily influence scoliosis expression. This is where hormone and neurotransmitter testing becomes crucial. Hormonal imbalances, such as low melatonin levels, fluctuating estrogen or progesterone, or irregular cortisol rhythms, have been repeatedly associated with scoliosis onset and progression during critical periods of growth. Melatonin, for instance, not only regulates sleep but also bone metabolism and growth plate activity. Disruptions in melatonin signaling can impair spinal development and lead to asymmetrical growth. Estrogen and progesterone imbalances affect ligament laxity and skeletal maturity, potentially contributing to curve destabilization. Similarly, neurotransmitter irregularities, such as deficient serotonin or dopamine levels, can impair motor control and postural reflexes, setting the stage for subtle but progressive spinal misalignment over time. When genetic, hormone, and neurotransmitter profiles are combined into a single, comprehensive assessment, clinicians are equipped with an unprecedented level of detail about the patient's internal physiological environment. This blueprint offers much more than diagnosis, it guides intervention. For example, if genetic testing reveals variants in vitamin D receptor genes alongside hormone testing that indicates suboptimal vitamin D levels and bone density markers, a personalized supplementation program emphasizing vitamin D3, magnesium, and vitamin K2 could be implemented to support stronger bone growth and reduce curve progression risk during adolescent growth spurts. Similarly, if neurotransmitter testing identifies low dopamine or serotonin levels in a patient with a COMT variant, targeted nutritional therapies, such as the use of L-tyrosine, 5-HTP, or specific B vitamins, could help optimize neurotransmitter function, improve balance and coordination, and support postural stability. Furthermore, Hormone testing may uncover imbalances that, if left unaddressed, would undermine physical rehabilitation efforts. An adolescent girl with high estrogen dominance, combined with a familial genetic predisposition towards scoliosis, might be at greater risk for rapid curve progression during puberty. Early identification of such a hormonal profile would allow for interventions such as dietary modifications, e.g., reducing processed foods, sugar, and endocrine disruptors, herbal support to balance estrogen metabolism, and specific exercise programs aimed at stabilizing the spine before curves reach surgical thresholds. Personalized nutrient therapy, when based on comprehensive biological data rather than general population norms, represents one of the most powerful tools in modern scoliosis care. It transforms passive observation into proactive prevention. Rather than waiting for a curve to worsen and responding with mechanical solutions like bracing or surgery, clinicians can now actively intervene at the metabolic and cellular levels to strengthen the patient's foundational physiology. Such interventions not only address the spinal curvature symptom, but also help correct the underlying internal environment that allowed scoliosis to develop and progress in the first place. Moreover, understanding a patient's genetic, hormonal, and neurotransmitter landscape empowers families. Instead of feeling helpless during the watch and wait periods traditionally prescribed for mild scoliosis, families can engage in meaningful, evidence-based strategies tailored to their child's specific biological needs. This collaborative, proactive approach often improves compliance, reduces emotional distress, and increases the chances of long-term success, allowing many patients to avoid the invasive, high-risk interventions that have historically dominated scoliosis treatment. Importantly, this integrative model respects the individualized nature of scoliosis. No two scoliosis cases are exactly alike, and therefore, no two treatment plans should be identical. A genetic variant in PAX1 influencing vertebral development in one patient may call for different interventions than a collagen-related genetic predisposition in another. A hormonal profile showing melatonin deficiency may necessitate a different therapeutic strategy compared to one showing excess cortisol. Each patient's unique biological fingerprint demands a customized care plan, a hallmark of true modern precision medicine. In addition, this multi-layered testing approach often reveals hidden factors contributing to scoliosis that would otherwise remain undetected through traditional orthopedic evaluations. For example, a patient might exhibit subtle mitochondrial dysfunctions or inflammatory tendencies, insights gleaned from advanced genetic and biochemical testing, that contribute to poor muscular endurance or increased oxidative stress at the spinal level. Identifying and correcting these metabolic deficiencies can enhance the effectiveness of physical rehabilitation programs, reduce fatigue, and optimize spinal health during critical growth periods. In conclusion, combining genetic variant testing with hormone and neurotransmitter profiling represents a revolutionary leap forward in scoliosis care. It moves beyond the outdated one-size-fits-all mentality and recognizes scoliosis as a complex multifactorial condition rooted in unique biological patterns. By using this detailed information to create personalized dietary, supplementation, and rehabilitation strategies, clinicians can not only address the obvious symptoms of scoliosis, but also the underlying causes, dramatically improving patient outcomes. This modern approach transforms scoliosis management from reactive to proactive, from mechanical to biological, and ultimately offers adolescents their best chance at living strong, healthy, and curve-free lives. Targeted nutrient therapies. Targeted nutrient therapies have emerged as a powerful and essential component of modern scoliosis treatment, offering scoliosis patients a proactive way to halt further spinal curve progression and significantly enhance the outcomes of scoliosis-specific exercise programs. Rather than relying on generic supplement protocols, today's advanced clinical models use the results of individualized genetic, neurotransmitter, and hormone testing to precisely tailor dietary and supplementation strategies to each patient's unique biological needs. Genetic testing can reveal polymorphisms in key pathways related to bone density, such as VDR for vitamin D metabolism or COL1101 for collagen production, neurotransmitter regulation, COMT, MAOA, and inflammatory processes, IL-6, IL-6, TNF-alpha. These insights allow clinicians to recommend specific nutrients at targeted doses that support optimal bone growth, improve postural control, and stabilize musculoskeletal integrity. For instance, Patients with a VDR variant may require higher doses of vitamin D3, often in the range of 2,000 to 5,000 IU daily, paired with vitamin K2 and magnesium to ensure proper calcium utilization and bone mineralization. Similarly, those with impaired collagen synthesis genes may benefit from therapeutic levels of vitamin C, 1,000 to 2,000 milligrams per day, silica, and amino acid blends to strengthen connective tissue supporting the spine. Neurotransmitter testing can uncover imbalances such as low serotonin or dopamine, guiding interventions like 5-HTP, L-tyrosine, or B6 supplementation to enhance neuromuscular communication, proprioception, and postural reflexes, critical factors in maximizing scoliosis exercise program outcomes. Hormone panels may reveal melatonin deficiency, where supplementation with 1 to 5 milligrams nightly not only improves sleep, but also regulates growth plate dynamics during adolescent growth spurts. If cortisol imbalances or estrogen dominance are present, adaptogenic herbs like ashwagandha or DIM and anti-inflammatory dietary changes can be recommended to rebalance systemic stress and hormonal health. By correcting these internal imbalances, targeted nutrient therapies create a stronger physiological foundation for scoliosis-specific exercises to work more effectively, allowing the body to build new postural patterns, strengthen stabilizing muscles, and reduce asymmetric forces on the spine. Without such internal support, even the best designed rehabilitation programs may achieve only partial success, as the body's biological environment remains unfavorable for structural correction. Thus, integrating customized nutrient therapy with active rehabilitation is not simply complementary, it is foundational. This personalized, data-driven approach represents a major advancement over older scoliosis models, replacing passive monitoring with empowered, precise interventions that can alter the course of scoliosis development. In essence, targeted nutrient therapies transform scoliosis treatment into a true whole-body solution, attacking curve progression from both the inside and outside, maximizing each patient's innate ability to grow stronger, straighter, and healthier. Reflexive response rehabilitation concepts. Reflexive response rehabilitation represents a groundbreaking advancement in scoliosis treatment, targeting the critical neuromuscular deficits seen in adolescent idiopathic scoliosis, AIS, by automatically recruiting the intrinsically controlled spinal muscles that are involuntarily weakened and uncoordinated in affected patients. Unlike traditional scoliosis exercises that focus on conscious, voluntary muscle engagement, reflexive response rehabilitation is designed to stimulate the deep postural muscles, the multifidus, rotatories, and interspinales, which are governed largely by the body's automatic nervous system rather than conscious control. This specialized approach uses resistance-based movements to trigger involuntary muscle activation, leading to increased intrinsic muscle strength, recoordination of abnormal muscle firing patterns, and the development of new neuromuscular feedback loops. By challenging the body against specific resistance patterns, the exercises create a powerful posture memory effect, where the brain begins to imprint a new, less twisted, and straighter spinal alignment based on consistent sensory feedback from the now properly firing spinal muscles. Over time, this rewiring of the brain's postural control centers allows for lasting improvements in spinal alignment without the need for conscious effort, ultimately creating a more permanent correction of scoliosis at the neurological level. Reflexive response rehabilitation can be implemented isometrically as part of a highly targeted scoliosis bootcamp program where patients engage in strategically designed exercises that isolate and strengthen the spinal stabilizers without movement, enhancing endurance and coordination. Alternatively, it can be practiced dynamically through the use of the ScoliSmart Activity Suit, a specialized device that applies gentle resistance across multiple planes of motion, forcing the body to automatically recruit the correct muscle groups during everyday movements like walking, climbing stairs, and postural transitions. The activity suit creates an environment of constant, low-level challenge, training the spinal muscles and nervous system in real-world functional activities, dramatically increasing the integration and permanence of the corrective changes. Whether performed isometrically or dynamically, the core concept remains the same: to activate, strengthen, and retrain the involuntary postural muscles, restore normal muscle sequencing and proprioceptive input, and permanently imprint healthier spinal alignment into the brain's motor patterns. Reflexive response rehabilitation addresses a fundamental problem in AIS: the failure of the brain to correctly perceive and maintain a straight, balanced posture. By reprogramming this faulty sensory input and motor output, patients gain the ability to maintain a straighter spine naturally without braces or constant conscious correction. This represents a major departure from older scoliosis exercise models that emphasized only superficial muscle strengthening without addressing deep spinal stability or central nervous system re-education. Through consistent application of reflexive response rehabilitation techniques, patients can build a stronger, more balanced spine that resists curve progression and, over time, dramatically improves quality of life. Less invasive, non-fusion scoliosis surgery. Less invasive non-fusion scoliosis surgeries, such as vertebral body tethering, VBT, and anterior scoliosis correction, ASC, represent a major advancement in the surgical management of adolescent idiopathic scoliosis, AIS, offering alternatives to the traditional, highly invasive spinal fusion procedures. Both VBT and ASC aim to correct spinal curvature while preserving as much of the spine's natural mobility and flexibility as possible, a critical goal, particularly for young, active patients. Vertebral body tethering involves placing a flexible cord, tether, along the convex side of the scoliotic curve through minimally invasive anterior thoracoscopic surgery. The tether is anchored to the vertebral bodies with bone screws, and tension is applied to partially straighten the spine immediately. As the patient continues to grow, the tension created by the tether gradually modulates growth according to the Hütter-Volkmann principle, slowing growth on the convex side and allowing the concave side to catch up, resulting in progressive curve correction over time. Similarly, anterior scoliosis correction, ASC, is a minimally invasive procedure that uses a small incision along the side of the torso to access the spine from the front. ASC typically employs a stronger cable or cord and allows for greater immediate correction during surgery, often used in patients who are closer to skeletal maturity. Unlike traditional posterior spinal fusion, which permanently locks spinal segments together, both VBT and ASC maintain motion across the treated spinal segments, preserving natural biomechanics and reducing the long-term risks of adjacent segment degeneration and reduced quality of life. Recovery times for VBT and ASC are often shorter than for fusion surgery, with many patients resuming normal activities, including sports, within a few months. However, these procedures are not without risks. Complications can include overcorrection, tether breakage, implant failure, and the need for revision surgery if growth modulation is not precisely balanced. Despite these challenges, outcomes for properly selected candidates, typically skeletally immature patients with moderate flexible curves, have been promising, offering substantial curve correction with maintained spinal function. Another important distinction is that because non-fusion surgeries preserve motion, they tend to produce fewer long-term problems associated with rigidity, chronic back pain, and compensatory joint degeneration compared to fusion. As a result, VBT and ASC are increasingly seen as more physiologically sound options that align better with the natural dynamics of spinal movement and whole body health. Still, careful patient selection, precise surgical technique, and long-term follow-up are critical to maximizing the benefits and minimizing the risks of these procedures. As surgical technology and understanding of growth modulation improve, the field of non-fusion scoliosis surgery continues to evolve, offering new hope for AIS patients and redefining the standard of care. Overall, VBT and ASC reflect a critical shift toward preserving spinal mobility and function, prioritizing quality of life not just in the short term, but across the patient's entire lifetime.